I love wounds, and I keep telling my residents and my interns and my nurses, they're like, what do we do with this wound? And I'm like, oh, I don't know. We'll need to go have a look at it. We need to talk to it. So there is some magic with wounds, and it's very difficult to teach. But one of the things I want to do today is kind of pass on some of that joy I have and some of the experience that I have, and just kind of inspire you guys as well to feel that kind of um, joy and willingness to deal with this, because I know a lot of vets are, and nurses for that matter as well, can be a bit intimidated by wounds, but really don't be, and don't feel you can't change the plan. The plan needs to be changed all the time. See what works. If that doesn't work on that one, do something else. So today we're going to talk about negative pressure wound therapy. And currently we're working with the system that Georgie is providing, which is this Aluco system. We've used it quite a few times. We've used it so much that we now bought it from her, because initially we would rent it. So we would call her up, go like, Georgia, we have a case. I think I need this. She can ship it overnight. We'd have it the next day. But because we deal with so many cases, in the end, we elected to just keep the system in-house. But there is a version where you can rent it on a case-to-case basis, which I think is really nice, so that the expense is not massive at the beginning, especially if you're in a smaller practice, or like me, have to do like a little business case every time you want to buy something. So this is very nice. The learning objectives for today. So what I'd like to do is just for you guys to have some confidence in what cases can we use this on? How do I do it? So this is very much a how-to. I am not going to go into detail about how wounds heal. Hopefully the majority of you know it. And those of you who don't, you're not here for that anyway. You're here to see how this system works, and some of the tips and tricks, and also some of the troubleshooting that we've had to do, especially because every time you work with a new system, I think this is the 4th system I'm working with now. And a lot of these things can be carried over to other systems as well. So even if you're not going to use the Aluco system, you can use a lot of the things I'm telling you guys today. But there are a couple of things that are specific to this system that we're just going to pass on, just so you don't end up running into some of the same problems that you didn't know what to do with, and then go from there. And then that's the tips and tricks. So they'll come scattered throughout as we go through the cases, and then at the end we'll follow up with a little list of the things. So the next slide is, what is the definition of secondary closure? So the correct answer is closure after granulation tissue formation. Now, secondary healing is where and that's a trick question, I'm sorry. Secondary healing is where the wound spontaneously heals. So I like to use our VAC, or negative pressure wound therapy unit, to produce this healthy granulation bed so that I can close the wound a bit delayed, so delayed closure once everything is nice and healthy in there. So for example, bite wounds, nasty infections where, cat bite abscesses, that kind of thing, where you really don't want to be closing it over because there's a lot of stuff going on underneath. And this way you can kind of suck all the badness out, get that nice healthy granulation bed where you feel nice and happy that nothing's going on that shouldn't be going on underneath, and you can then close over it. Now, I'm going to show you a couple of pictures. So these 2 next slides have patients on them. And these are cases, and there's an extra slide as well. So I'd like you guys to consider which ones of these are good cases for negative pressure wound therapy. Now, I'm really sorry, there will be a Slido come up to kind of put this in. So if you could make a little mental note of A, B, and C, it could be 1 or 2 of them. There's also D, E, and F on the next one. So then once we get to the 3rd slide, that will be where you can put in your answers. So have a good look at these. Think, where could I get good granulation beds? So I could do, for example, secondary healing or a secondary closure, or for example, also use it for grafting. So I sometimes use the units so that I can get that great granulation bed so I can put a graft on top. So have a look at these and see which ones you think might be a good candidate for the VAC. We will get through why they are or why they aren't. And then we'll go to the next slide. And then there's these.
So I hope you've all made your mental notes. So a lot of these cases are good cases for this. One of the reasons why we didn't use it on the foot that much, or at least in the setting that it was, is because it's very difficult to get a good granulation bed directly onto bone that way, and it was very difficult to get the back in between the toes. I think we ended up amputating 1 or 2 of those toes and then getting a granulation bed, or we could drill some holes into the bone and then try to get the vac in between the toes. But it's difficult to get a good seal on that. Now, the one right next to the penis, so we'll go back a slide. So this one in the middle, that's a good candidate because we have a nice area where we can put our foam or cling film down onto. The pantarsal arthrodesis, so that's actually been reported as well, where to get some granulation tissue over it, and the vac is really good at that as well. But we all know it's very, very difficult to get that granulation bed over that metal bit, but it is possible. I'd actually even say the D might be an option. It just depends a little bit on how creative you are. The thing is, D, we don't really need it because there's already good granulation tissue there. Then we have the cat, and I don't remember if you saw that. That's that one on the right here, the C. Initially, I wouldn't have said that that was a good candidate because it's so close to the anus that the cling film would have probably gone over it and made that difficult. But one of my tricks is I partially close them. That way I get a bigger area where I can put my film over. And I can put my foam in. And instead of the foam just filling in that little bit that we can see, you can actually also put the foam into that defect, so into the dead space that's under the skin. So I do that sometimes where I do a partial closure just to get it a bit easier to get our foam in there, but also because this will heal this way anyway. So why not starting to get that, because there was enough skin to do that in that cat. This cat had a TIOR because I didn't have access to a vac when I was doing this one. But had I seen this week, I would have probably offered the client a vac treatment for this patient. Perfect. Let me just see if we have any questions that I need to deal with right this second. I can't see that. Georgie, anything we need to deal with before we move on?
No, we're all good. Thanks.
Perfect. Great. So this first case that we're going to have a look at is Nico. Nico was/is still an 8-year-old male neutered large breed dog. The owner this time last year ran over Nico with his pickup truck, both front wheels and back wheels. He presented to us with a urohemoabdomen as well as multiple pelvic fractures. So Nico went through a lot and was not easy to handle or manage at all. He was very scared. He was in a lot of pain. He'd bitten the owner as he tried to get him into the van, and was challenging for the team to deal with as well. So changing bandages on this dog wasn't easy. Initially, of course, we didn't have to. As the soft tissue team saw him in, we did surgery to remove his kidney that had been macerated basically by one of the wheels, so there was no kidney left. That was where the blood was coming from. And I also put his bladder back together, which was where the urine came from. He then, the week after, went on to have surgery with the orthopedic team to have his pelvic fractures sorted out, which went well until we had a surgical site infection and wound breakdown. So when we have wound breakdowns, and this is generally, we always lavage, so cleaning, and we debride. If tissue is dead, it is not going to come back to life. If it's dead, it needs to go. There's no reason to go like, oh, I don't want to remove it because it might do something. It's not going to do anything. It actually might do harm. So if anything is dead, you need to debride it. It needs to disappear. And then lavage. And one of the things that I like to do is I either like to have a pressure bag with my fluid, so I don't mind if I use saline or Hartmann's. Or you could do, if you don't have a pressure bag, or you have a band, which I had for a while because I kept breaking so many of them, then you put a giving set in, a 3-way tap, a hypodermic needle, and then on that 3-way tap, away from the hypodermic needle, where you just remove the metal bit so you don't poke anyone. Also almost got banned for that. You put a 10 or a 20 ml syringe, and then you get really nice pressure where you can lavage the wound. There's also, of course, the option where you can put a needle directly into your bag. It's very difficult to get that pressure, especially when you have to go through a leader. You get tired from just pushing on it, but that's an option as well. So this is Nico's wound. As you can see, it's closed at the caudal part, okay? So that's just where the incision was, and it's the cranial part that broke down, but there was a deep pocket underneath. There was quite a bit of infection in there, and Nico wasn't very easy to handle. So we were talking about potentially doing a tie over. We couldn't close it because that wouldn't have been ideal with the implants and everything in there. So I'd like to treat it open first until we had the granulation bed and then do our secondary closure. But because Nico also wasn't eating very well, we had to anesthetize him to put a feeding tube in. So we thought, well, we'll anesthetize him, we'll put the feeding tube in, and then we'll debride, we'll lavage, and then we'll place the vac. And then how do we do that? So this is a how-to now, because we got a lot of very nice pictures out of this that one of, well, generally my brilliant nursing team did. And I had Rachel Potts, who's one of our nurses that really like wounds, put this together and sent these pictures to me because, of course, I lost them because I'm a surgeon, so I lose everything. So thanks so much, Rachel, and Stephanie. Thank you as well, because I'm sure you were there. So the way I do this to make sure that the foam fits perfectly is I take a swab, I place it on top of the wound, and then when you take it off, you can see it makes that outline perfectly of how big the wound is. You cut that out. It's just arts and crafts, really. So if you're crafty, this is brilliant. So you then get that thing, you can see it fits perfectly in there, and then you place it on top of your foam, and you have tons of foam. Don't worry about it. If you can AFHEA in your clinic, I'd recommend that you AFHEA the rest of the foam, because then you have extra in case you need something for a different time. But again, I think at this point I have so much extra foam, I don't have enough cling film or dressings or anything else, so I need to start throwing my foam away because I never use all of it. So there's tons of foam in these packages that Georgie sends to you. So this all has to be done sterilely, of course. So sterile gloves, prep the area, use sterile instruments for this because we have to treat it as a surgery so that we don't introduce any bacteria. So this is all done sterilely, and then we clip it out with scissors, sterile scissors, and then we place that. You see how that fits perfectly into that defect. Now, this is where you're going to need a sterile assistant because the cling film is clingy. It is super clingy, and it's made super clingy so that it kind of sticks down to that patient. If it accidentally falls over and touches itself, you can't uncling it. So the trick is you hold it on either side and stretch it out. Then you take, there's two sides to it. So you take that protective off, and as you take that off, make sure it's still stretchy and your assistant stretches it, because you don't want it to accidentally fold, because then that's it. You're going to have to get another piece of cling film. You then place that down on top of where you're going and place it down straight and firm, because we don't want any creases. Every time you get a crease, there's a risk that air might come in and go in there, and then you have a leak and it's not going to do what it's going to do. So we need to close this down so that there is no leaks at all. So get your assistant, stretchy out, put your hand on it, push it down on the other side and push your hand down on it. Okay, so you can see there how the assistant is like holding it down while the other person starts gently, or both of you starts gently peeling away the top bit, because it's very malleable. That top bit is on there so that it's quite straight. Be careful as well here that it doesn't crease. It's quite nice how it's placed here on the right. You can see this isn't the first time we're putting this on Nico, because there's some yellow blobbins, and I will tell you in a second what those yellow blobbins are. And they were there before we put this on, so this is the second time he has one placed. So now this is placed over the patient's nice and evenly spread out. But where you can see those yellow blobbins, that's his groin, and you can imagine as he walks around, every time he moves that leg and it goes like this, he's going to pull on that film, and that film's going to start coming off. And it's not a very long distance between the groin and that foam, and air is going to go up there, and then all is lost. So one of the things you can do is, if you have an area like that or there's a little bit of a leak, is you can go on Amazon and you can get this stoma adhesive, £11.55 or something. It's stoma paste that's used for colostomy bags. It is exceptionally sticky, super duper duper sticky, and it gets a little bit hard. So usually what I do is, if I'm doing one of these, before I start everything, I take this paste in the tube, I put it in my pocket, and that way it's nice and warm. Or actually, I give it to somebody who's not sterile, and I put it in their pocket, and it's nice and warm, because then it becomes more malleable. The only way I can really describe it is it's a bit like caramel. So as soon as it comes out of that thing, it just sticks to everything. Everything gets sticky. So what I like to do is I like to just lift the sticky bit up in that area. You can see there where the yellow bit was, and then push it in. Don't start putting it on your finger and going out. It'll be everywhere. It'll be in your hair. It'll be in your tea that evening. It'll be everywhere. So put it directly on the skin. And if you needs be, put your finger on it and move it around, but then change your glove right away, because that sticky stuff is everywhere. It is literally like the stickiest caramel you've ever seen. You can also get little double-sided sticky tape also for stomas. I couldn't find one that I liked last time, so I've used this, and it's actually quite cheap. It doesn't last forever, but it does come with Amazon Prime, so it can come overnight, so when you need it. And what happens over time is that once it's sat there for a bit, it cures and it becomes quite hard. So you can see some of that stoma paste is still on Nico from last time. And it is a little bit difficult to come off. So what we normally wait for is that the hair grows out a bit, and then I can cut it away, or we just let it fall off over time. But it also works as something for the tape to sit onto next time, and I can put more of it in. But that's a good little extra trick. I'd love to take, I mean, I'd love to think that this is my idea, but it isn't. It's something I've learned from one of my supervisors when I was at Cambridge, and it works a treat. So stoma paste or sticky stoma tape is something that can help you if you have a little leak somewhere and you can't deal with it. Now, we're going to have to apply the tubing, and the tubing comes like this, where it has that cup that sits onto the foam, and on that cup there's then your tubing that goes up and it sits onto a canister. The cup also sticks down, so that paper that's on there you have to peel off, and then it'll get sticky. But as you can see, we're first going to see where we're going to make this hole so that we have contact between the suction cup and the foam. We're going to have to cut a small hole through our sticky drape over the foam. So normally what I'd do is I'd be like, I want the cup to be about here. Also, just think about which direction you would like the tubing to go, just so that it's easier for you to handle afterwards. So you know before you start taking that protective layer off and it gets super sticky. And because once you stuck it down, it's stuck down. You can't get it off, because if you try to lift it off, it's going to rip that sticky drape that's already on the dog, and then you have to start over. So have an idea of which direction you would like the tubing to go, a bit like when we put drains in. Hold it over, and I kind of lift it up and see, okay, right, that's where the hole is. This is where I need to make the hole in the drape. Remove it, I get my sterile scissors out, and I cut a little hole. It's somewhere around 5 to 10 millimeters in diameter. And we just cut that away, remove it, and now there would be a connection between them. I then take it and stick it down. And this is what it looks like. And then I then attach it to the side of the machine. So when you have the machine on the side, there's that hole on the end, and that's where you put your tubing in. You can reuse your canisters. So until they're full for the same patient, don't mix them between patients. But if there's still room in that canister at the time where you're changing it, so this is 3 days he's had it on, and now he's having it on for another 3 days, you can just use them again. The machine will tell you once the canister is full and when you need to change them, and then you change them over, and you can order them separately as well. You don't have to have, so the canisters come separately from the packages with the foam and the cling film and the suction tube. So you put that in, and then the trick is that when you turn the machine on, yourself and your helper need to go over and put your hands back on that film. So push down on that film down onto the patient so that all that stickiness, that when you apply the vacuum, it goes down, because what you don't want to have is that there is somewhere where there was a little bit that was lifted up, and then you apply the negative pressure and it doesn't close down, and then you have a permanent hole. So go over, push down on it on either side, and then turn the machine on, and then you'll hear it goes, and that's a good noise. We like that noise. And then you can see everything just contract down. You can see the foam contract down. You can see your drape track down. And then you'll hear a tucking noise. It goes tuck, 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 tuck. And this is what it's supposed to do. That's the pressure and the constant little bit suctioning that's going on. But if you hear this noise again and again, that's the machine that's resetting itself and going like, wow, there's not enough pressure. I need to pull out all the pressure. That might mean that you've got a leak somewhere. So just go back and then listen to it. So stick your ear down and go like, I can hear it goes like somewhere, and then find it. Put your finger on it, see if it stops. If you can find it, it stops, and then you can put a little bit of your stoma paste in there and stick it down again. Wait, listen to the tuk, 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 tuk. And if it says that, we're all great. Happy days. Everybody's happy. So this is what the canister looks like when it's attached. And as you can see inside of it, there's a little pouch with some white powder. And on the side, that's where you put your tubing in. Once wound fluid goes into the canister and gets suctioned in, that little baggie will dissolve. And you can already see it starting to dissolve up at the top, because we have used, I think this has just been turned on. And it makes the wound fluid into a slushy. And it does that, I think, for multiple reasons. There must be an antiseptic in it, usually, that kind of just controls everything. But it also makes the wound fluid less fluidy, so more viscous, so it doesn't just slush around like this, because that would maybe be a problem for stability. So it just kind of makes it into slushy. This is what it's supposed to look like. That does not mean that the fluid that's coming out of your dog looks like a slushy. It is that little white powder thing that's in there, so don't get too worried. The setting that I normally use for these is 125 millimeters of mercury. Now, there are different settings if you're using them over, let's say, a graft. We go a lot less pressure on those, I think 70 to 80 millimeters of mercury, but a standard for a wound would be around 125. We tried to go with a pulsatile suctioning on this unit, which is what I've used before, so more of a cycle. And it didn't seem to work very well because it kept losing pressure too much. So for the Aluco unit, I used the consistent mode. So that's where you have this streak that goes, so you can set the different modes on it. But after speaking to Georgie, we decided to just do continued suctioning, and that seems to work really well for this unit. So that's what we've stuck to. So that's what I would advise as well. Now, it'll sometimes lock, so you'll have to unlock it. So hold that unlock button in for a bit, and then it unlocks, and you can start it up. So this is, again, you can see we're holding that down as it starts up. So that's what it looks like when we turn it on. So hold that down, get a third person to push the button so it starts, and then it sticks. And as you can see, we had to apply a little bit more of that sticky stuff, the adhesive, and that just goes there in the groin. And I had to be a bit careful because he also had some burn wounds but he had some irritation from his sticky drapes that he had on in theater. So I was trying to go around them a little bit. It's not the stoma paste that's caused these burns. It is the sticky drapes that went on him in surgery. So I was just trying to go around that as much as I could. So when we have our slushy, it's all good. But what we've also found is that I like to have the machine in with the patient because the tubing isn't super long. So it comes with a little bag. And I was like, oh, we don't need it in a bag. We'll just put it on the floor. And I put it on its side. So the machine was lying down so I could see the reading on the end. And then the canister was lying down. But what we found was that sometimes the slushy would go into this little canister. You can see just over where it says the number 2. There's slushy in that little bit. And as soon as slushy goes in there, the machine thinks it's full And while this canister still had room for more, it wasn't full. So what we started doing now is we've left the machine in the bag and then we have it upright. So we have it standing up. Go back to the slide here, like this. So that the white bit's on the top, the slushy's on the bottom. And then we have it in the little bag that it's provided with. And then we hang that inside the kennel so that the slushy doesn't go into that compartment at the top and we don't lose a whole canister for this. And because it stops working, and it always is at 2 a.m. in the morning when it's a night team that's not comfortable with the unit and don't know what to do, and then you get woken up and then you have to go back in. So that's why we hang it in that bag, and it just goes on a little hook in the kennel and it works brilliantly. But that little bag is also very important because you can take them out for walks. So this is Nico out for a walk. There we go. So he can lie on it, he can walk with it. He's doing really well. So as you can see, the nursing team is doing a really good job with him, carrying that bag. Well, I would have said bag, but no, but carrying the unit around. But you can see there's a strap in it. The pressure changed here, but that's probably because we're moving with him. As soon as it went back, it went to 125. Now, one of the things I like about the unit as well is that when we take this foam out, and also don't leave it for more than 3 days, because the foam is porous, and at some point when it develops granulation tissue, the granulation tissue is going to grow into that foam. So it does provide me with a little bit of debridement in itself, but if you leave it for more than 4 days, as you pull out the foam, you might end up leaving foam behind inside the granulation tissue, so I wouldn't leave it any longer than 3 days. Oh, not that video, this one, if it'll work. There we go. So when you pull it out, comes out like this, again under general anesthesia. But as you can see, it provides a little bit of debridement there as well. And this is why I really like it for preparation for grafts, because I then have that nice fresh granulation bed. But again, this is healthy granulation tissue. It's not hair that's in it, that's strands of the suture material that was used for the closure. But this is what it's supposed to look like. Again, if you feel, I think we actually closed it this day, but if you feel it's not quite ready yet, then you lavage it again, debride whatever you need to debride, and reapply.